Good afternoon and welcome to our webinar series focusing on long-term ventilation in children and young people. My name is Marilyn McDougall. I'm the Clinical Director for the South Thames Paediatric Network. I will be speaking on behalf of both the South and the North Thames Paediatric Networks. Throughout this series of webinars in September, you will get a chance to meet clinicians from a variety of places, including the paediatric respiratory centres across all of London and the wider region, representatives from the Well Child Organisation, as well as members of the North and the South Thames Paediatric Network team. I would like to thank Erigen, who sponsored this series of webinars. You're probably wondering, why have we chosen to deliver this set of webinars now? Well, firstly, COVID derailed our plans to deliver a hands-on workshop in April. So for those of you who were unable to attend the April events, we hope that you find this series of webinars just as useful. Secondly, as network teams, we often receive questions about managing this complex group of patients. This is your opportunity to hear from the experts and to ask those burning questions. Thirdly, and importantly, this is a group of patients who are increasing. In 2014, it was estimated that there were about 1,400 children across the UK who required long-term ventilation, whilst the 2020 NCPOD report identified over 3,000 children across the UK on some form of respiratory support. This includes both invasive and non-invasive ventilation for any child who requires support for more than 3 months. Before launching directly into today's webinars, I would like to introduce a few key people. Firstly, from the Pan-London Long-Term Ventilation Group, Emily Morn and Gemma Bridger. The Pan-London Ventilation Group brings together the expertise of all the respiratory centres to standardise competencies and share best practice.
Hello, I'm Emily Morn, Well Child Long-Term Ventilation Nurse Specialist at Great Ormond Street Children's Hospital.
And I'm Gemma Bridger. I'm the Education Lead for the Central Children's LTV team based at the Royal Brompton.
And together we chair the Paediatric Pan-London Long-Term Ventilation PPL LTV group. It's really great to be able to collaborate with the North and South Thames networks to share knowledge on LTV in this much needed September Pan-Thames LTV best practice event. The PPL LTV group is a working group of clinical nurse specialists and allied healthcare professionals supporting children requiring long-term ventilation, both invasively via tracheostomy and non-invasively via mask ventilation. It's representative of all of the main LTV centres across London: Gosh, Brompton, Evelina, King's, Royal London and St George's hospitals. Following successfully setting up and chairing another Pan-London group in 2016, the Paediatric Pan-London Oxygen Group, PPOG, aimed at standardising the discharge process and the home oxygen service in general for paediatrics patients across London, we identified that there was a need for a similar group and more collaboration across London for LTV2. Currently, there's no standardisation in education or advice, which is an issue because patients move between hospitals either once they've been discharged or even in the discharge process. General hospitals and community teams often support managed at different LTV centres and receive different advice, which can be confusing. Carers often care for a few patients at different LTV centres, and they can receive training from several different centres, again, with differing advice, again, causing confusion. There's minimal evidence base and minimal guidance for LTV in general. And in general, this is confusing, causing complex discharges to be even more complex, causing delays and inequality in education and advice. So at the end of 2018, we formed the PPL LTV group in order to improve services, work more collaboratively together, and where possible to standardise and manage the management discharge process for children requiring long-term ventilation across London, hopefully improving the quality of care as well. So we're a CNS and AHP-led group. However, all work is taken back to individual LTV centres for peer review by relevant nursing, medical and allied healthcare teams. We work collaboratively with other relevant local national groups in order that the most thorough and up-to-date guidance and advice is provided. The work that the PPL LTV group is undertaking has taken on increasing importance recently following the PICS review and the recent NHS England focus on LTV. And it links really well with the important improvement projects proposed by the North and South Thames networks with whom we're working closely. We're really excited to share with you some of the projects that we've been working on and collaborating with the teams in the up and coming webinars.
So as a group, we identified projects that we all felt really passionate about and we felt would make a real difference to our unique patient group as well as those providing care to them. So the two main projects that arose were competencies for parents and carers and escalation plans for when our children become unwell in the community. And it's really interesting that this, at the time that we were doing this, the South Thames and North Thames networks were having the same conversations in various working groups around LTV. So it was reassuring to us that we were all on the same page and actually we can now share that work with the networks. The competency group brought together all the different frameworks that are currently used within the group in the hope that we're going to formulate one pan-London document that will look at tracheostomy, invasive ventilation and non-invasive ventilations, which my colleagues will give you some more information in the webinar later on. We then looked at the escalation plans and again looking at creating one document that is easy to follow and can be used within the community settings to provide those caring for our patient group a very clear patient-specific guidance when the child becomes unwell. And again, our colleagues will be updating you more on that in another webinar. I think for us, our group really came to life during COVID-19, which I appreciate we're still in the sense that we started having weekly calls to help each other out with the same queries, worries and problems that we were all receiving from healthcare professionals, from parents, from other hospitals. And this included looking at an alternative equipment list because a lot of our children were struggling to get the regular equipment that they always have because of the pressures of COVID-19. And we looked at also creating some resources to support centres who were potentially going to have to look after our children because they weren't able to come into the acute services due to COVID-19. So this included looking at videos, quick guides, just a sort of toolbox for those centres to be able to pull out that information as and when they needed it. And it was also an opportunity for our group to support each other because obviously our roles did change during COVID and due to redeployment, a lot of community and community teams were redeployed, so we were able to sort of pull together as a group to ensure that parents and community teams still felt they had that support out there for these children in obviously such an unusual time. And again, that was work that we did with the South and North Thames just to sort of spread that message and spread those resources far and wide so we could really make sure that it was also going out to those sort of community DGH settings as well. We're really pleased that we're part of this September sort of series of events. It's great that the LTV and our unique sort of patient group is out there, and we're looking at the care that's provided to them, not in just in the acute centres, but in the community and DGH settings as well. And it's been a fantastic opportunity for us to work, as I said, with other networks and other groups to really create, you know, a standard and a good quality of care for all of our patients, irrespective of where they are, either in their discharge journey home or whether they're in the community already. And we really hope you enjoy the month. Thank you very much.
Thank you.
Miriam Khabib is the project manager for the South Thames Paediatric Network. Miriam has worked tirelessly to bring together patients, commissioners and clinicians to ensure that all stakeholders' opinions are taken into account when planning for the future.
Thank you, Marilyn, and hello everyone. My name is Miriam Khabib. I'm the project manager for the South Thames Paediatric Network, and I've been leading the LTV program for both the South and the North Thames Paediatric Network. I'll be very brief, but I think it's important to introduce the different organisation, agencies and professionals who've been extremely supportive over the past year and a half, and without whom there wouldn't really be an LTV network. So if I can start with the London tertiary centres, Evelina London, Great Ormond Street, King's College, Royal Brompton, St George's and Barts, and all the district general hospital across the South and North Thames Paediatric Network. Then the community services, which play a pivotal role in ensuring good transition from hospital to home and in ensuring continuity of care for these children in the day-to-day life. Then the continuing care teams and CCGs and our 8 STPs. I would like to thank particularly South East London STP, North Central London STP, and Surrey Heartland ICS, which been incredibly supportive and helpful in informing our understanding of continuing care for children and young people, and particularly informing our understanding of the importance of paid carers for the in supporting the day-to-day care of children on long-term ventilation. Next, two groups, two Pan-London groups, the Pan-London LTV group, chaired by Emily Moan and Leila Holden, and you've just heard from Emily and Gemma talking about the group, so I will skip to the Pan-London Ethical Framework group, which is chaired by Dr. Joe Briley and Richard Shabazz, with invaluable input from Marilyn McDougall, Kathy Brennan and Sophia Tisani, just to mention a few, but the group got good representation for a broad range of professionals, and you will be hearing about the ethical framework in one of the next week live webinars. And finally, NHS England, NHS Improvement, and I want to thank particularly Kathy Brennan and Rachel Lundy, which again have been extremely supportive over the past year and a half. And then I would just like to mention a few governmental departments which again are critical for improving the LTV pathway for children and young people, which are the Department of Health and Social Care, the Department for Education, and the Ministry of Housing, Communication and Local Government. So I will stop there and I'll hand over to my colleague.
I'm going to hand over now to Stacey Bedford, who is the nursing lead for the Paediatric Critical Care South Thames Network, and Jackie Edgecombe, who's our Allied Health Professional Critical Care lead for the Paediatric South Thames Network. They are going to speak about the models of care and how to standardise practice and learn from each other across the region. But before I hand over to this lovely team, I have to say a huge thanks to both of them for all the work that they've put into preparing these workshops and also supporting colleagues during the COVID crisis.
Hi, I'm Stacey Bedford and I'm the nurse lead for the Paediatric Critical Care ODM for South Thames Paediatric Network. When looking at the various work streams surrounding LTV in children and young people and the breadth of professionals that are involved in these work streams, it's easy to lose sight of the main goals and hard to pull together these complex projects in a way that feels meaningful. To keep the focus of our intentions, we have to repeatedly return back to the aim to deliver the right care at the right place at the right time. Practically speaking, this requires us to hone in on the recognised gaps in service and also hone in on the best practice and what is working really well. Much of the activity to date is being fed into a document that we've been referring to as the Model of Care for LTV in CYP. The hope is that this document will provide us with the signposts and direction needed when the complexities of LTV begin to blur our vision. It's really about establishing the ideal patient journey in our region and then about making it happen. The main documents that help us to set standards for LTV are the PIC standards for level 1, 2 and 3, which are currently quite focused on tertiary centres. The Healthy London Partnership Paediatric Critical Care standards for level 1 and 2 offer a much more focus on delivery of critical care outside of the tertiary centre. And the Paediatric Service Specs for LTV and Respiratory Services. Rather than creating a whole new set of standards, We're focusing on providing clarity on which standards apply and when they apply, and highlighting where the gaps are. The first standout area for practice is the District General Hospitals caring for LTV. Whilst all District Generals providing inpatient paediatric care are expected to meet Level 1 paediatric intensive care standards, as well as acute care standards, we know that the right place for LTV families is often in their DGH when the time is right. Many DGHs are providing this service and are providing it to a high standard. We want to simply provide clarity in which additional standards of care should be applied in order to make this step consistent and consistently safe and improve the experience for both the service users and the service providers. This is about asking, what does a good service look like and how do we make it happen? One of the most important aspects of this is having the correct resources available to the teams and ensuring that competence and confidence is where it needs to be. One of my colleagues from Pan London LTV Collaborative will talk in more depth regarding this.
Hi, I'm Vicky Robinson, non-invasive ventilation clinical nurse specialist at Great Ormond Street Hospital.
My name is Gemma Bridger. I'm the education lead for the Central Children's LTV team based at the Royal Brompton. And today we are doing a very quick presentation on some work that we have been doing within the network, looking at tracheostomy LTV and NIV from an education perspective, looking at things from a DGH perspective. So first of all, we kind of focused on, so what do we know? And we know through data that has been captured across the Pan-10 region that some DGHs do provide care for children with either established tracheostomy with or without long-term ventilation, as well as children with chronic non-ventilation. And we know that this can be, whether it's on the journey from hospital to home, as well as whether this can be when the child becomes unwell and needs to go back into some sort of hospital setting. However, the number is really quite small. In the recent NC-POD report, it highlights that only 6 to 18% of our patients are admitted to the local DGH, and we contrast this with 46% of those being admitted to a PICU. And it's interesting that this admission to the PICU isn't always necessarily dependent on actually the child's clinical need. It's more that is the case of that's where the bed and the staffing and the expertise is. So what is the reality? So we know that not all DGHs currently provide support for whether it be LTV, tracheostomy or NIV children, whether it be for step down from tertiary centres or whether it's for acute admissions. Those that do, there is a variation in the standard of care being delivered from centre to centre, and there's also been variation in the education that the staff receive. We also are very aware at the moment with the growing pressures in the PICU settings, that there is a keen drive to start upskilling those staff in those hospitals to provide this care. But what we want to make sure that it is obviously still evidence-based, it's standardised, and it's obviously maintained in line with the current PIC standards.
This also includes the District General lead nurses, paediatricians and ED consultants, the North Thames Paediatric Network nurses, educator forums and the Pan-Thames LTV Collaborative. The education workstream stemmed from work already started by the team of clinical experts known as the Pan London Long-Term Ventilation Group, and the aim of that group is to ensure practice is standardised, is evidence-based, and to ensure clear communication for clinicians and for the families. And also a wider representation of the working group ensures that education packages like this one that we've developed is in collaboration and it's agreed with all the key stakeholders, that it's sense checked and it's fit for purpose outside a tertiary centre in a district general hospital where you may not see as many ventilated children as would be seen in a tertiary centre. So the education bundle should comprise of a competency framework for district general hospital staff. This competency framework is, like we said, it's designed to be standardised. It's been designed across the London centres and has been sense checked with district general hospitals to make sure that it's at the right level for the right people. There is a competency sign-off guide for assessors. So it's like a rationale between the competence that we are expecting and a rationale. So it should be able to be done by any of the trainers or super users. A standardised education and teaching skills. These have been developed with the same format across NIV and LTV to make it easier to teach across a broad range of areas. Quick guides and for common ventilators. We thought this would be really helpful because we know that you may not see these ventilators as often. So if a child on a ventilator was to come in and you hadn't seen that ventilator for 6 months, it would be a quick A4 piece of paper that you could go to with photographic guides and cues on how to set up that machine. That would also involve troubleshooting. We're hoping to set up an e-learning package. This would be great for updates also, which we know is a problem in keeping up to date with competencies. Videos for clinical skills and ventilator setup, some of which you will see during this Ventember webinar sessions. Standardised teaching plans, lesson plans for core local group training, again to make sure that it is standardised everywhere we're going to train. And local link teams who will undergo in-depth trainer sessions. And this will be this will help sustainability. So we're going to ensure that the correct contact details for the initiating centres are within those resources too, so that everybody knows who to contact and how to contact for the extra support. But also those online videos should do that as well. And these can be accessed at any time and maybe support with those 2 AM questions. We essentially want to provide them with a toolbox of resources that they can utilise at any time to support them. This will enrich the support teams for the families and ensure all professionals have access to the same resources and support regardless of the capability and resources available from each of the leading initiating teams, which we know can vary across the London region. So I guess it's how we're actually going to do this well. We're hoping that it will be one trust will take on a pilot, which we're hoping will be Luton and Dunstable. And we're just going to start it with one trust at a time at first, just to see how this runs. Then hopefully we can do them parallel. So the initiating centres, alongside the district general educators and super users, will deliver a two-day study day, both covering NIV and trachea long-term ventilation, which will include physiology, AMP refreshers, practicalities, troubleshooting and practical workshops. So all the things that you need to practically look after NIV and LTV in your area. There'll be resources available, as previously mentioned, that can be used at any time as refreshers, but also on patient admissions as a guide. And this should reduce the dependence on the individual clinical nurse specialist teams who may not have the capacity to support all the training and 24/7 support for local centres, which makes this programme sustainable. The competencies have been agreed across the London centres and with district general hospitals, as previously mentioned, but they don't have to be signed off using a live subject, as this isn't realistic, and it's something that we are doing within the tertiary centres to gain competence for HDU level care also. And as said, these competencies it's a pan-London approach, so they have all been agreed, and that's with the PCC educators and lead clinicians and the nursing team. We hope to do update training because this is always a concern, and especially if you don't see these patients that regularly. So we aim to develop a comprehensive e-learning package to support this, as well as closer links with the initiating centres for more immediate help and support whenever it's needed. I'll just pass you over to Gemma now, who's going to explain some of the work done.
So here are some examples of some of the work that we've been doing as part of that education bundle. So we have created a long-term ventilation via tracheostomy, essentially a PowerPoint presentation to support the hands-on practical training that the trainer will take out, and we've done one for non-invasive ventilation as well. And these also include looking at the most common ventilators that we use within the North Thames. We've created these very quick guides, as you can see on the screen there, that again, as Vicky highlighted, are those things that you can have in your toolbox at 2 AM when you need to put out when it's just something that you can't quite remember. It's a very easy way to just refresh your memory and your learning. So the next steps for the group are?
So the final sign-off and formatting for the competencies. These are days away now from full sign-off, and that is also alongside the sign-off guides for the assessors and learners that I was talking about earlier. So these should all be finished by the time this goes live. We need to finalise an e-learning package for the update and to use as a resource also. And we are hoping to host this on an accessible site. We're just looking into the resources currently for that. We need to upload the clinical skills videos to the Pan London YouTube channel, which again, hopefully most of those will be done by the time this goes live, as they're going to be shown during Ventember. We're going to create standardised training and lesson plans for the super users, so that the lessons that they are going to provide without us being there will be standardised also. And support the first District General led Train the Trainer sessions. We already have a pilot centre set up, and the training slides and competencies have been agreed by all of the District General lead clinicians. So overall, we hope that this education package will develop the skills of local clinicians and nursing teams, with enough support in place for the District General teams to feel competent and confident enough to accept NIV and Tracheostomy LTV patients into their local centres for step down or repatriation when unwell. Not only will this improve PICU capacity across London, but this will ensure that the right patient is in the right bed at the right time, and improve the care and holistic support for these children and their families and what they receive.
So many thanks for your time, and we just want to say, as an opportunity, to say thank you for all the teams that have been working with. A lot of work has been going into this, not just from the teams that both Vicky and I work with, but from a South Thames and a North Thames perspective, and we appreciate that, especially with the times that are currently ongoing, people that have been giving up their time to look and review our documents, and the positivity that has come from it has really been fantastic. If you do have any questions for us, both our contact details are on the slide there. Please do email us. If you've missed some of the work that's going on and would like to be involved again, please do email us, and we hope you enjoy Ventember.
Jacqueline Adjicum, and I am the Allied Health Professions Lead for the South Thames Paediatric Network. All of our therapy services play a key role within the patient journey for a child with LTV needs. For all of the pieces of work being discussed, we are working collaboratively with a range of different professionals who are committed to improving patient care across the long-term ventilation pathway within our region. One of the areas that has been highlighted for focus, along with the standards and competencies for District General Hospitals, is the standard for paediatric physiotherapy covering acute and community services. Physiotherapy plays an essential role within the management and care of children with long-term ventilation needs. From initial discussions with therapy colleagues across the region, we have found that there is variability regarding physiotherapy cover and skill mix. Early work is underway with a group of committed paediatric physiotherapists to clarify what the standard should and could look like, and how we can streamline the training and support offer available to the physiotherapists within the region. Within this, we also understand that area-specific commissioning arrangements can have a huge impact on the availability of services within an area. The second most important gap that has been highlighted is the journey through services at the point of discharge and beyond. This will form an important element of the model of care, but leads me to explain another important aspect of the work ongoing within the Long-Term Ventilation Collaborative. Children initiated on long-term ventilation, it may be that for various reasons they are unable to return to their current home. Establishing a family's current housing situation and whether, if initiated, they can return to their current property is a key piece of information that needs to be ascertained at the start of admission. It is also important to acknowledge that parental wishes in terms of accommodation, not only for the child with long-term ventilation needs, but for the family as a whole, can also impact the housing options that their family feel they are able to accept. Additional issues within our region relate to the availability of suitable housing options for the short and long-term needs of children requiring long-term ventilation. This can contribute to significant delays in discharge as well as causing distress for families. Supporting and managing discharge is an area that requires a multidisciplinary approach and covers a range of professionals that work within acute, community, local authority and education services. Not all the areas that discharge children from hospitals have the same access to the range of professionals that are required to support discharge. They work hard to provide services within limited resources. World Child Charity and other centres had already commenced a piece of work around a discharge package that can be used as a resource for centres across the region and beyond. Within this, the paediatric networks hope to tie together all of the existing work streams that relate to discharge and bring them together into one discharge pack. We know that some centres have excellent, robust discharge processes, but for those that do not, the aim will be that this resource can be used and adapted based on local needs to support a young person's discharge home. It is hoped that the pack will include the following documents: discharge planning paperwork, home visiting documentation, discharge checklist, the escalation plan for children with long-term ventilation needs, relevant equipment pathways, and a training pathway for carer competencies that will span across the region. If this is an area you are interested in being involved in or hearing more about, then please contact the paediatric networks.
Thank you for your time. This is an update on the progress of a regional project to develop a standardised escalation plan. This started as a project identified by the PPLTV group, and we are representing this subgroup working on the plans. This project links in with identified paediatric network objectives. Often these children are very complex and require lots of care at home. Parents and carers know the child well, but require clear guidance of how to manage a child's deterioration at home and empower them to know when to seek clinical review. All respiratory teams have their own plans of which they discharge the child home with from the centre, and the aim of these plans is to help families and teams to identify when the child becomes unwell and requires escalation of care and what to do in this event. The advantages of a standardised format will mean that it's recognisable to teams both in the community and in a hospital setting, and both from a managing centre and a district general hospital. As part of the project, we wanted to use the people that will be involved in using these escalation plans to be involved in developing it. The advantage of a standardised escalation plan is that it will be recognised by all centres that use them.
So in terms of the process and where we're up to, the subgroup from the PPLTV group was mainly made up of clinical nurse specialists and AHPs from around the region. So what we initially did was to sort of get some guidance from other centres around the country. So we asked out for existing templates that other teams used, and also got some examples from community teams as well. Then as a group, we sort of agreed on the key content that we felt needed to be included. We wanted to have really clear signs within the plan that identified what might constitute a respiratory deterioration. And we also wanted to include sort of very clear actions that family and carers should take at home or in another community setting. It should include some contact advice, and also sort of very much when to attend hospital for a face-to-face review. Based on the experience of teams around the region, we also thought it was important to have some guidance included for the district general hospital teams to use within A&E, so that they had some sort of key points from in terms of the respiratory team's recommendations. So we got hold of quite a few existing templates, and then the draft that we agreed to use and work up as a template for our region was actually from an Australian plan that's been used for a while. So the Queensland Health Authority have actually got a traffic light system which they use for their respiratory patients discharged from any respiratory centre. We thought the traffic light system worked quite well. It's often used in other areas of medical care because it's very visual and it's very clear for users, hopefully, to identify what's normal in a green section, what's sort of yellow demonstrates a little bit of concern, and what's red more of an emergency. So as a little group, we worked up a template, one for NIV patients, and then it became clear that actually it needed to have slightly different sort of pointers and recommendations for those patients that also had a tracheostomy for their ventilation. So we worked up a couple of drafts, and we then shared them with community teams around the region and with some care providers, because we very much wanted feedback from
different stakeholders that would need to be able to use it and need it to be fit for purpose. It was also very helpful to have input from DGH leads as well for exactly the same reason. So where we're at now is we have 2 draft versions. They look very similar, as I said, but the prompts are slightly different on the tracheostomy and the non-invasive version. On the reverse side of this, there's also some guidance for the local hospital. The idea is that the prompts will stay the same on the template, but the clinician completing it will be responsible for all the information that sits within it, because they're the experts in that child's care and they understand the needs and the sort of escalation required. So that remains very much with the team completing it to add detail. I don't know whether you can read the sort of headings for the different prompts, but the idea is that the left side of the template describes what a carer or a parent might see. So it's broken down into the sort of appearance, breathing, secretions, cough, things like that. And on the right-hand column are the actions that we would expect someone to take and the recommendations for what they should do. So that might include things like reducing their activity if they become unwell, or changing hydration, or maybe using different ventilator settings, because some centres use sort of unwell settings whilst they're seeking review. So there's also a guidance document that we're working on that will describe how to complete the form itself and what things to include in different sections. So it's still a work in progress. In terms of the next steps, we are now circulating the 2 draft templates to the bigger PP-LTV groups. That's most hospitals around the region are represented in terms of their CNSs and physios and OT. Our hope is that we can pilot this from a few centres in September onwards, but we're very much open to feedback along the way. So again, if anyone's sort of looking at these and would like to look in more detail, we'd be really grateful for any feedback. With Jackie's help, we're hoping to get some PPI feedback, so get some additional feedback from families and carers, as that would be invaluable. Certainly we have been using this so far, and the initial feedback from families is quite positive, which is a good start. We'd like to be able to finalise the templates by October time, because as we're all aware, escalation plans are very much utilised over the winter, so it's useful to have them up and running as soon as possible. Initially, those are going to be in paper form or electronic form, but I think the longer term plan is that we had some very interesting discussions about maybe using the Coordinate My Care platform, and depending on how the pilot goes, if we get to the point of having a standardised template, it might be great to be able to incorporate that onto a platform that London Ambulance Service and District Generals and GPs can all access much more sort of remotely, rather than a sort of emailed or a paper version. So that's a summary of where we're at. It's just 2 of us here today, but obviously it's a group effort, and as I said, we're very much keen for anyone's feedback and suggestions along the way. So for now, thank you to the PP-LTV group for all their input, to the network teams for sort of driving this on, and for our community colleagues, and especially to Sarah Wright and the Queensland team, who've kindly said that we can adapt their home respiratory action plan for our use. Thank you. Welcome to this webinar on competencies for parents and carers. My name is Gemma Bridger. I'm the education lead for the Children's LTV team based at the Royal Brompton.
Hi, my name is Billy Coverley. I'm a respiratory CNS at King's, and I specialise in NIV and LTV.
So we're going to talk about the competencies for parents and carers that the PANS London Long-Term Ventilation Group have been reviewing. As Emily mentioned earlier in the day, we are a group of clinical nurse specialists and allied health professionals expert in the care of paediatric tracheostomy, long-term ventilation and non-invasive ventilation from all of the main London specialist centres. And what was it that we were looking at were specifically for competencies for parents and carers. And this came out from identifying work that we felt passionate about as a group, where we really felt that we could make the difference for our children. So what do we already know? So we already know there are some various competency documents utilised within the London tertiary centres. Obviously, we've got the RBH and GOF ones, and there are ones from Evelina as well. And they're all to facilitate the training of a parent or carer to be able to safely look after that child at home, whether this be on tracheostomy long-term ventilation or non-invasive ventilation. But essentially, the skills within the various documents are all the same, irrespective of whether they're taught by one centre or another. And what else do we know? We know these different documents cause confusion for those trying to look after our children in the community, and also causes difficulties with our own centres when we've got carers coming who've been trained in one centre to look after a child, who will then come to another centre to look after a very similar child, and we have to start that whole training process all over again. So what can we do about this? I'm going to hand over to Billy for the next bit.
Yeah, so what we did was we came together with the idea that Gemma was explaining, that we would create one competency that would go pan-London. And so there would be one for tracheostomy, one for invasive ventilation, and one for non-invasive ventilation. And then with this, what we wanted to do was provide a set of guidance notes, both to support the learner, but also to support those that are teaching the competencies, so that there was consistency with what was being taught across London. So what we did within the group was we first identified who the key stakeholders were, because although we're all nurses that work in ventilation and allied health professionals, some work just within LTV, some work just in NIV, and some do a mix. So what we wanted to do was identify the key stakeholders for each competency. And then out of those people, some took active roles in actually producing the competencies, and then some were reviewed some were involved far more in the review process there. So after that, what we did was we collated all the competencies from the different centres and from one of the hospice. We collected everything together, and we tried to amalgamate everything there was, so we didn't miss anything, and so that everything, so there wasn't duplicates in the competencies. So after collating the competencies, we then went through a review process. So we wanted to make sure that everything was up to date with current practice. We wanted to make sure that it was comprehensive, that everything was in there that we wanted to be in there. And we wanted to make sure that it was transferable for use in all centres, so that, a competency that was applicable in one place also worked in another place, because using different equipment and different machinery, sometimes the competencies from individual centres didn't necessarily transfer well to others. So we worked on that to make sure that all of the competencies transferred well to each centre. So what's different? Well, we wanted to try and make it more child and young person focused, and the tracheostomy competencies now include cuff tracheostomy tubes, double lumen tubes, and subglottic ports. And I'll hand over to Gemma, and she can tell you what else is different.
And for the ventilation competencies, what we've tried to do is make them more generic, so they can be applied to any device, and that obviously fits in what Billy was mentioning earlier, that actually that makes it more transferable from centre to centre. And as Billy mentioned earlier as well, we're trying to make it more child and young person sort of focused as well, especially looking at how our sort of older cohort of patients that we are now seeing. So where are we now? So a number of our colleagues in the group are piloting them to ensure that they actually are a working document, and we're doing this within our centres at the moment. So those that that contributed and put together the competencies are now piloting them, as I said, to see if they actually do work as a working document. And then following that, Our next steps are obviously just to review, make any changes post-piloting, which we envisage will be minimal. We then obviously take every competency to individual trust guidelines to get them signed off for approval, and then we'll be publishing the competencies for this pan-London use. And there are our contact details, so if you do have any questions and queries, do feel free to contact Billy or I. And we do hope that you enjoy the rest of September, and we hope to hear from you guys soon, and thank you very much.
Hello, my name is Emma. I work for the Children's Long-Term Ventilation Service. We'll just be covering securing appropriate housing in the discharge planning process for long-term ventilated children. We looked at data over a period of years and found that for tracheostomy ventilated children who didn't have a suitable property, their average additional delay to discharge was 94 days. The reason for this is that there is a housing crisis, which is essentially a shortage of affordable homes. There's a number of different factors which affect that, including not enough social rental properties available, a large increase in the private rental sector, an increase in homelessness, and higher housing costs across all types of tenures. And this has had a direct impact on our patient population. So we recorded data including the number of days until identification of a suitable property, and we found that the longest waits had been for families awaiting a home through their local authority or local council's housing register or housing waiting list. The first chart here in blue shows the number of people on a local authority's waiting list in the year that a tracheostomy ventilated child from that borough's need for housing was identified. The second chart here shows the number of days the child in that borough had to wait until a suitable home was found through the housing waiting list. And the parallels are really remarkable. There's a very clear correlation between areas of an acute housing crisis, such as in this graph, Southwark and Lambeth. LTV children there are likely to be waiting longer for a suitable home than children in areas with less of a housing crisis, or where there's less people waiting on the housing waiting list, such as in Hammersmith and Fulham. So we want to house the LTV population safely, quickly and efficiently. But how do we do that? I'd say we need to HIC to avoid housing hiccups. That approach is a holistic approach. So there's lots of different stakeholders and multidisciplinary professionals involved, and there's lots of factors which will affect that journey from hospital to home. Getting holistic support, including families being able to access other support services, is really beneficial to the journey. For instance, a welfare advice service can support with rehousing or maximising income to meet ongoing housing costs. The intervention needs to be early. We need to start thinking about housing solutions as soon as we start thinking about a child being long-term ventilated. Home assessment should be put in place as soon as possible, even if a child isn't yet medically fit for discharge. That early intervention can make a huge impact in identifying whether a property is suitable, whether adaptations can be made, or whether a new property needs to be sourced. And communication, as we said, there's lots of different stakeholders involved. And that holistic approach is effective when there's communication between the stakeholders involved, and that information is shared and disseminated so that everyone involved can work to find a positive solution together and collaborate to meet that shared goal of getting the child home to a safe, suitable property. And compromise. So you may need to compromise on everything except safety to be rehoused more quickly. Perhaps a property offered to a family isn't in the area that ideally like to live in. I'd just like to touch on a method which is available through legislation to hospitals to help them discharge patients if their homes aren't suitable. This is an intervention, and it's called the duty to refer. So essentially, public bodies, that includes hospitals in their capacity of treating inpatients, have a duty to refer those who they think may be homeless or threatened with becoming homeless to a local housing authority or council. And the support the council can offer can include advice, emergency accommodation, agreed steps to prevent homelessness or relieve someone from homelessness. And that could be temporary accommodation until settled accommodation is available. And that settled accommodation might be private rental, or it could be a council tenancy. Whatever it is, it does need to be suitable for the child. We just want to demonstrate how this sort of approach works. First patient we use this on what we'll call patient W. Family were homeless, the child was going to be a paediatric wheelchair user, and in addition to not enough bedrooms, it was also up a number of flights of stairs, it wasn't suitable for discharge. We made a referral to the local authority where the family lived, day 1. By day 16, following assessment, the council had offered support to the family. They'd agreed to support this family both in the short and long term. By day 19, offer of accommodation was made. By day 21, through liaison with the local community OTs and nurses, that property was viewed and assessed. It was deemed as suitable. And 23 days after that referral to the council was made, a tenancy was signed. This was for a fully wheelchair accessible property. It was temporary accommodation, so it's not going to be the family's long-term home, but it was able to address the housing needs which they had, and it has the potential to turn into their long-term home too. I think this duty to refer really demonstrates how that holistic approach, working with different services, an early intervention, communication and compromise, parents had to accept the property because it was suitable, really helped to actually resolve the housing barrier to discharge within 23 days. So for tracheostomy ventilated children in London and the South East region, the Children's Long-Term Ventilation team at the Royal Brompton Hospital can be contacted for support with discharge, including support with rehousing options.
So we reached the end of our time today. Thank you so much for joining us. I appreciate this is a recorded webinar, so you won't have the opportunity to interact with speakers, I'm afraid. But if you do have questions or comments, please email us. You can see the email addresses on the screen, or use Twitter to make comments, and you make sure that you use the hashtag LTV in CYP. We are really keen to address what things that are on people's mind, especially as we progress through this series of events. Make sure you don't miss our next webinars. Register at stpn.uk/Pantems LTV and CYP. You will only get CPDs from RCPCH if you register and attend the webinar on the day. So we're going to be back tomorrow. Tomorrow will be a live webinar, so you will have an opportunity to interact with speakers. The topic is lessons from COVID. You will be hearing from the Evelina London and King's College respiratory team, and from Wellchild around how they responded to COVID and what they've learned from it. Next week, there will be 2 live webinars, one from the Pan London Ethical Framework Group, which will explain the work around creating a consistent approach on decision making. And then the webinar on Thursday 17, you will be hearing from the NCPOD team around their research study and their recommendations. The following week, we've asked some of the members of our network to present some of their local work, on how they've improved the experience of patients and families locally. And then on Thursday, 24th of September, we've asked the Evelina London team to share their expertise around neonatal weaning, the permissive hypercapnia concept, and LTV and heart involvement. And finally, the last week of our series of events, Wednesday, 30th of September, will be a webinar. We called it A Peek into the Future of LTV, and we're really hoping to give you a flavour on how the LTV community is changing and advancing technology in ventilation. Last but not least, 1st of October, the Aerogen team will discuss with us nebulizer therapy, and we will be showing a simulation that we're hoping will help you strengthen some practical skills around a number of areas, including NIV interfaces, respiratory assessment on an LTV patient, suctioning, tracheostomy, and emergency tracheostomy change. So finally, I just want to say a massive thank you to Aerogen, who is sponsoring our series of events. And I want to say a massive thank you to everyone who's contributed to today's webinar: Marilyn, Emily, Gemma, Stacey, Jackie, Vicky, Jade, Ruth, and Emma. And then a massive thank you to Teresa, Davey, and Fern Griffin, who've been fantastic in coordinating all the work behind this series of events. So thanks, and I hope to see you tomorrow.